Thank you, Helen. And what I'm not going to say, you will say after the break, I think. So, why and how to identify NAFLD in primary care? I think it's a brilliant idea, Jörn, and your co-organizers to organize this in the middle of a Mediterranean diet thing. But I heard in the break that alcohol is rising in Spain also. So, yeah, it's a kind of a mixed culture here. So we are going back, ladies and gentlemen, to 1947, where the GP was really a GP. He was in his own house. He has his own gun there. The whole family is present, and the practitioner is all and one attention for the patient, person-centered care at that time. Now, this has, in the Netherlands at least, been changed. These are some practices I photographed in my area. This is my practice. It is only in a village of 2,000 people, and we set this €1 million costing building there. So a lot of things has changed, and now the question is, has this been influencing person-centered care? So this is the 3 doctors of our center. We have 4 assistants, so always more assistants than doctors. And then we have 6, 8 nurse practitioners in the practice. So in a village of 2,000 people, we have this team. So this perhaps gives some challenges and opportunities. And I think when talking about the values, the core values, somebody called it nuclear values, because the nuclear is the same word in Dutch as core. But these are the core values of general practice. And one of them is what John also talked about, is not keeping an overview of the medical care and providing direction, but also providing optimal care, not too much and not too little. So the major shortcomings, I think, and if I look into my bosom, would be that rushed practitioners do not follow established practice guidelines, which were already mentioned. We lack still, even with this big team in my practice, we lack care coordination, and we cannot go for an active follow-up to ensure the best outcomes. We are stuck to the model of the 7 minutes I heard just now, but we have 15 minutes consultation, and that's our window to the reality. And I think we have to do, and that we will talk to this tomorrow. We are not educated to train patients effectively to manage their diseases, their illnesses. And in general practice, we have this steep curve of when you get older, the more and more comorbidities arise. And of course, this team of 15 people have to look not only to the liver, but we never looked to the liver until now, until this day, until I got invited to Barcelona. But we look to all other things: type 2 diabetes, chronic kidney disease, cancers, cardiovascular disease. And these chronic diseases follow-up and monitoring is based not with the doctors in the Netherlands, but with the assistants and with the practice nurses. So the practice assistants do the intake, the video calls, the exams, so they can do CRP, they plan the consultations, but the practice nurses, they do consultations in chronic care, in asthma, COPD, diabetes, in elderly, complex elderly, and cardiovascular risk management. And then you see that the 15 minutes they have 30 to 45 minutes per patient several times a year. So there's an opportunity there to test and to broaden the horizon of primary care to perhaps another factor, which is liver. So this practice nurse or specialized nurse in the primary care in our country is introduced in the late 90s. And now in approximately, I think, 90% of general practices, they have this specialized nurse. I think it's the same with you in the UK. So different duties they have compared to the assistants. They guide and care for patients with a chronic disease. They develop care protocols for specific groups, and they do the care and the checkups, but also home visits for complex elderly disease. So the focus is the patient with a chronic disease, and Jörn asked about follow-up. They have those protocols that say, well, when you have COPD and you have this lung function and you have this kind of burden of complaints, then you come into a protocol of follow-up, periodic controls and checkups. And they have a key role in guidance and informing the patients, but also they have their focus is also on prevention, on care-indicated prevention, as we would say. But this is, of course, a American study. Sorry, the nurse practitioners' knowledge and preparedness to deal with the care for patients with non-alcoholic fatty liver disease is not optimal. And you see the answers to the question: I have the needed knowledge regarding NAFLD to diagnose, manage, and refer these patients. So a lot of nurses are not into the educational learning curve, ready for this. So, and what I already said, not you, you're great guys, like liver specialist and stomach and maag-darm-nevenartsen. Okay, but cardiologists see us like this. So we have to do this from the side of preventive cardiologists. And you see here that they even think about you. So it's nearly impossible to do all this in general practice. And then we have, I didn't hear the word yet, we have health illiteracy in practice. I have people who studied medicine, who studied at the university, but if I check them for health literacy, they score low. So it's not one-to-one related to their educational status, but the satisfaction with what the GPs advise, the access to health info and understanding what the health info means, and even to talk to physicians or nurses about their liver or even about diets, which is a very difficult thing for doctors because they never learned to talk to patients about diets and about lifestyle. And especially in people who have low health literacy, that's an extremely difficult thing. So sorry for a bit pessimistic talk, but we will find a solution in 2 days in this meeting. So lifestyle counseling. So both in this study in the Netherlands, both GPs and practice nurses they perform lifestyle counseling. But for both, there is a big room for improvement because they should learn more about motivational interviewing, about detailing about lifestyle, about diet, about nutrition. So I think efforts needs to be put into integrating such techniques into the busy daily practice while simultaneously complying with the many other clinical demands. So I don't know whether artificial intelligence, like the previous speaker was trying to sell to us, is the answer, but there has to be done something. Integrated care. In the real world, you see that even in the outpatient clinics of you guys, that you fail to refer to physiotherapy or a good dietitian. So there are only a few integrated multidisciplinary clinics that have their program in place. So this is a website for patients in Dutch that we often use as an addition to our consultations. It's this is I have a fatty liver, and then they can see videos, films, education about fatty liver. I think many people, also people with low health literacy scores, they do well with certain health apps. So years and years we thought, well, the 85-year-old patient, they will never do something with an iPad, but this is rapidly changing. And integration of the contact with the practice nurse, with the doctor, and with the health app is perhaps the circle that, or the impetus that moves the circle to a better quality of life. But this is from the Netherlands, the UK, but I think South America has other challenges. There is much more fragmented healthcare system, which is a barrier to integrated and multidisciplinary care. And I think my colleague who's married to a GP, I think your wife would think it would ease things up when GPs were taught to think in different categories, like fatty liver disease with subcategories, alcohol, virus, non-alcohol. That's what we understand. We don't understand the liver function tests. That's the evaluation also of medical studies that people cannot. So I really believe in your system, but also the definitions, I think, should be more operationalized for GPs. So coming to almost the end of my talk is that we at the European Society of Primary Care Gastroenterology try to update and upgrade the knowledge of GPs and their practice nurses on non-alcoholic fatty liver disease. And that we find that in guidelines there is not too much coherence. So many guidelines even my 110 guidelines for the GP in the Netherlands, not one mentions even non-alcoholic fatty liver disease. So our hope is, apart from the practice nurses and health apps, to digitalization in primary care. I think digital healthcare is the way forward. Also, seeing that the workforce in the Netherlands and also in the UK is many GPs stop with their work. There are no successors to go to the practice. So I think e-health should come in to use the data to get an interaction like in the liver function tests algorithm, and to help informing, monitoring, and follow-up. We learned in the COVID period that we had much more video consultations with patients, email consultations, but we have also a e-specialist consultation, which works very well. So with the we did an evaluation from my department for internal medicine, and we saved a lot of referrals to internal medicine, and we could send in our electronic patient record to the specialist. He or she gets rewarded for that. He sends us an advice, and with that advice we could go further. So we must decrease the workload in primary care, because if we want to do NAFLD and rheumatology and diabetes and that is not sustainable, because staff is becoming scarce. I think we in the Netherlands, we have now 1 in 7 people working in care, in healthcare. It will become 1 in 4, but we cannot pay that in the same range. So enough is enough in Dutch. So that this was our okay, go back. This was our logo when we went on a national strike. We had a strike for 1 day that we didn't work as a GP. So all the work got to the practice nurses. So, and apart from the work force, also the stress level in primary care is gearing up. I read a report yesterday also from the UK GPs, and I think perhaps in other countries that's the same. One consolation is that we have this quiz in the Dutch TV, doctors versus internet, and we still win. the quiz. So that's the thing. And I think the patient of the future wants shared decision making. He wants to measure and monitoring itself. So we as specialists, we want to monitor the patient, but also patients want to monitor themselves. And I think the monitoring, what they do themselves, will motivate them also to adapt and comply. And my take-home message is that I think case finding is the only way that we can do at max in primary care, and we can do it in the chronic care disease management programs. I don't think we can integrate it with our daily consultations. And we have the availability of an interprofessional team which works according to multimorbid disease management protocols. We should update and add NAFLD to our practice guidelines. We should find a way to deal with health literacy problems. And of course, we did a small pilot with a mobile fibroscan in our practice. Some firm gave it to us. And so we found an 85-year-old guy with almost, how do you call it, phase 4 fibrosis. But then the discussion begins. And then we know him. So the result does not lead to a referral to a hepatologist. He wants to stay at home. So the age and the comorbidity of people in primary care, you cannot put it all in an algorithm. You have to share the decision making about these things. I talked about digital healthcare, and I think when this awareness in practice nurses and in general practitioners would have increased by these kinds of education, I think the connection with the public health is should be strengthened, because when the bus stops at bus stops, you can hang posters about some conditions. So some like the flu vaccination or anything else is reinforced by public health actions. So I would also plead, if we go this way, if NAFLD is such an important thing for primary care, we should more and more connect with the public health officers. So I hope to see you at the next International NASH Day, which is in June, and which is organized in Maastricht. Thank you very much.